So I can fully appreciate, in more recent years, I've kind of made this disclaimer, because as we start getting into different types of diseases in this class, oftentimes there's an emotional attachment for many of you, because in the beginning, when you're talking about inflammation and wound healing, it's maybe not that difficult of a topic. But then you start moving into more complicated diseases, like maybe you knew somebody or had a loved one or have a loved one that's suffering with Alzheimer's. That's a tough topic to be talking about. And then we get to, for example, cancer. And nowadays, don't show hands, but now I would imagine everybody in this room has been impacted by cancer in some way, shape, or form. Okay, whether maybe it's an immediate family member, maybe it's a friend or a loved one, or in the very near future, you will. And so this one can bring up all sorts of different emotions. Okay, so if we get to a point in the lecture, and some of you guys know that my mother passed away from cancer not that long ago. It was like 3.5 years ago. So obviously the semester that she passed was the most difficult to talk about, and then it got obviously a little bit easier every semester afterwards. And so what I think is kind of cool is to be able to talk about her disease and what we can learn, and have my students learn from what my mom went through and what we learned in the process. But all of you probably have these kinds of stories. Okay, so I fully can appreciate if it gets too much and you just need to, kind of take a time out, just get up and go. The lecture will be online, so you can always pick up where you left off. You won't hurt my feelings whatsoever. Okay, and that'll probably continue as we get into some of the more aggressive diseases. Now you're starting to get into territory where it's not just all about the mechanism. Now there unfortunately might be sort of an emotional attachment to some of these diseases. Fair? So let's talk about cancer, because we're going to depersonalize it as much as we can so that we can get into the material. But I recognize that every now and then there might be something that just comes over you, and you don't have the ability to control those types of things. So what is cancer? Let's define it to start. So what is it? Well, cancer is really when normal cells lose their regulation. So cancer is your own tissue, your own cells, and they've mutated. And they are now no longer responding to normal growth signals. Normal growth signals, they either say you should grow or you should not grow. So cancer is not contagious. You can't catch it, right? It's not airborne, like some of the other diseases that you hear about in the news right now. I think we've talked about this. Many times you might go visit somebody that is wrestling with cancer, and either they're wearing a mask or you're wearing a mask, or both situations, and you're washing your hands, and you're actually more dangerous to them than they are to you, because you can infect them with viruses and bacteria that they're not capable of handling, especially if they're immunosuppressed, meaning that they're responding, or they're under a chemotherapy treatment to kill the cancer. It also, unfortunately, kills your immune system at the same time. And we'll talk about some of the treatments on Wednesday. We won't get to them all today. Okay? We won't get to any of them today. So the good news will happen on Wednesday. We're going to unfortunately talk about a lot of the bad news today about what happens with cancer. Now again, cancer biology, we could teach an entire semester-long graduate course in cancer bio. And again, I am not an expert in cancer, but I did learn quite a bit walking through it with my mom, more than I ever really wanted to know. Okay? It's a fascinating field. And my best friend from college is an oncologist. And he's in the Midwest, and of course when Mom was wrestling with cancer, we were on the phone every single day. I was picking his brain about everything, different types of drugs, different clinical trials. But again, and that's where we talked about this, that's where I kind of came up with this idea of, man, the next invention within medical care needs to be patient advocacy. Like, we should be training future healthcare providers for a job as a patient advocate, because you kind of need to be an expert and then like a really good communicator to explain it to the patient and the patient's family. what are these drugs? I can't even pronounce the frickin' thing. What is it? And then they have two names. They've got the chemical name, and then they've got the company marketing name. Does that make sense? And so you're like, wait, isn't it the same thing? Well, it is the same thing. So cancer is your own cells that have gone astray. And it's uncontrolled cell growth, like the slide illustrates. And you get this tumor formation. So you've got a muscularis mucosa of the gut. Okay, this would be the intestinal tract. And you get a dysplasia. What's a dysplasia? What's that term? It's a malformation. So these cells become malformed. And when they become malformed and they start looking different, you know something's up. And then you get what's called an in situ, or which is referred to as an in location neoplasm. Neoplasm is just a word for new growth. So now it grows outside of where it's supposed to be, and then it becomes invasive, and it actually starts penetrating into other tissues. And it becomes invasive, it starts migrating, or what we call metastasizing. It goes other places. So let's talk about benign versus malignant, because it's terminology that's thrown out there. And the example that I'll use is, let's say grandma or grandpa is worried about some skin lesion, or there's a history of colon cancer, and they do some imaging, and they say, you know what, we've got a lesion there that we want to go take a biopsy and look at it. And then the results come back and they say, good news, it's benign. And you're like, sweet. I have no idea what that means, but he said it was good news, or she said it was good news, okay? Or we're worried about where this thing has gone because it actually is malignant. And you're like, what does that mean? That's the bad kind of cancer. So what's the difference between benign and malignant? So benign is a terminology that's shown on the left side of this slide, where you've got characteristics like it's slow growing. It has a low mitotic rate, right? So cellular divisions are not rampant. It is well-defined, or it has a well-defined border. What does that mean? Well, that means that it hasn't necessarily broken out of the area that it's supposed to be. It's actually confined or retained within a particular area, like this leiomyoma right here. It's still in the original spot. It's non-invasive, which means it has a defined border. It's not going other places. It's not invading other tissues. And the cells are well differentiated. What does that word mean? That means that they are terminal in their shape and form of the tissue that they're supposed to be in. So for example, this is the endometrium. This is the myometrium. So this is a muscle layer. So if it is well differentiated, those cells in a benign tumor in the myometrium of the uterus are going to look like smooth muscle cells. They're differentiated as smooth muscle cells. They still look like smooth muscle cells. Here's a cartoon drawing of smooth muscle cell histology. That's well differentiated. Okay? There's no metastasis. A metastasis is a portion that is broken off and it has migrated something else. When it's metastatic or it metastasizes, it breaks off and it goes to a secondary location. So in a benign tumor, we have no mets or no metastatic breakoffs. Typically, when it's benign, we call it non-cancer, or some would call it pre-cancer. Well, it was pre-cancer. We caught it early enough. So what the heck are they talking about? They're talking about all of this over here. Is it normal tissue? No, it's not. It's not normal. It's far from normal. But you've caught it early in the phase where if you treat it or surgically remove it, the patient will probably be fine. Okay? Here's another example. Let's say you got a mole on your skin. And, it's gotten bigger. And your physician says, that mole looks a little suspicious. Have you noticed it change? I was like, it looks a little bigger than it did maybe last year. So they say, well, we're going to watch it and see if it gets irregular or if it gets bigger even more. Because it maybe got bigger because you grew a little bit, okay, if it's your pediatrician. But what they're doing is, and maybe they photograph, a lot of dermatologists will photograph lesions on the skin with a ruler to see if it looks different shape-wise. It was round and now it's irregular. So all of those clues are going to be non-defined border, right? It's becoming invasive, and maybe it's changing. And so they're just going to come in and say, I think we're just going to get rid of this thing. Let's play it safe. So that's another way that conversation might happen. And probably some of you have had those kinds of conversations with your doctors about like a mole or some sort of skin tag or lesion or whatever. Okay, they're pretty common. So the question is, if you have malignant tumors in secondary sites and you remove them, does the primary tumor know? I haven't seen any data to suggest that there's signaling that's that sophisticated. But no, really what the problem is, and let me just address your first comment, is when you remove a secondary site, that primary tumor that created the secondary site is still in the process of throwing out mets. And so a lot of times when you find a secondary site, you have no idea where else the metastatic lesions could have gone. You just found the one that probably became symptomatic. But a lot of these mets may be asymptomatic for a long period of time. Basically, they go undetected, and then you realize you have an issue, right? And I mean, that happens a lot in medicine. I mean, it's happening right now, as you guys know. There's a lot of people that are discovering, a lot of communities that are discovering that the coronavirus has been there for a while. It's just been undetected, and people were asymptomatic. Okay. Yeah, I mean, yeah. I mean, most people don't, wake up one morning and go, golly, my hip seems like maybe it's cancerous. It's like it hurts. It's painful. And they don't understand why. And they're feeling lethargic, and they're starting to lose weight. And then they decide, I'm going to go see the doctor. And then the doctor starts asking questions, and they say, let's take a look at your hip. They take some pictures, some imaging, and that's when the lesion shows up. But how long has it been there? It might have been there for a year or two. They just never knew it. Okay? So, I mean, that was the case with my mom. My mom had a lesion in her lungs, and it went undetected, probably for 5 or 6 years, looking back. Not because she didn't get it looked at, but the doctors couldn't see it. They didn't know that it was there. She had chest x-rays, she had imaging, and they just couldn't see it. Well, they didn't do an MRI back then. They thought it was a respiratory infection. So. It's happening already today. The question is, are there going to be more like preventative measure imaging that takes place? Yeah, there's actually businesses that do it. You can go to a mall and get a full body scan now. You can walk in, pay the money, get a full body scan, and they'll tell you all what's wrong with you. You could do it now, but do you want to know that? It's the question. And then who else is going to know that information? Like, is your insurance company going to find that out? And then you're going to be on some list? I mean, there's all sorts of ethical questions, right? Okay, so let's finish this out. Oops. So malignant, and then I'll answer more of your questions when we're talking about malignant. Malignant is different. Rapid growth, high mitotic rate, undefined border. It invades local tissues or distant tissues, surrounding tissues. And we'll talk about how it does that. It's poorly differentiated. So what's the contrast between well-differentiated and poorly differentiated? So if it's supposed to be a muscle cell, it's not going to look like muscle tissue. It's going to have backed up in differentiation, and it becomes less identifiable, and it looks less like it's supposed to. So for example, this histology here does not resemble smooth muscle cell histology. And this is less differentiated or poorly differentiated. So these cells are becoming basically less behaved. if you think about it in this context. Over here, all these cells are behaving like muscle cells. Here, these cells are starting to do whatever they want. And they are not behaving like muscle cells. They're behaving like other types of cells that are invasive, that are going to break off, divide, and go somewhere else and become something that's not muscle. A metastasis is possible, and we definitely call this cancer. So you can see here, this leiomyosarcoma is aggressive, and it's invading other tissues. There's another thing that you can call here, you can list as a detail, is oftentimes they have a necrotic core, and that's what this picture is illustrating. The histology shows a necrotic core, and even this schematic diagram shows a necrotic core. Why do you think there's a center portion of the tissue in a malignant tumor that often is necrotic? Why would that be? Any ideas? That's exactly right. So as this grows, it grows so quickly that the vascular supply can't keep up, and so the center of it becomes necrotic as it continues to grow outward. Make sense? What's that? So, yeah, so the question is, can dogs smell cancer? So there are theories around dogs being able to smell. What they're probably scenting isn't a cancerous cell. They're able to smell if this is necrotic tissue or has pus in it. They can detect that, and they're like, it has to be fairly substantial for them to be able to smell it. But yeah, that's absolutely a possibility, is they're able to smell this type of cancer. Okay? Yeah, we're getting there. Hold on. Just relax. Let it come as the slides come. We're getting there. You got great questions. Hang on. Neoplasia. Okay, this is a new growth. Okay? A new growth. These neoplastic cells are said to be transformed. They're transformed, meaning they're changed, because they replicate outside of normal cell cycle regulatory influences. So if you think back to basic bio, okay? So instead of going forward, we'll talk about new vasculature here in a little bit. I want you to go backwards. I want you to think about basic bio. And you talked about the cell cycle. And you talked about certain checkpoints where you pause to check the integrity of the DNA, okay? With cancerous cells, oftentimes those checkpoints are gone. They ignore them. They don't pause, they don't stop, they just rush right through it. The analogous would be you come up to an intersection and you see that it goes yellow and you know it's going red, and it hits red before you enter the intersection, and you just keep going. You don't even look to see what's going on. Okay? So this is what we mean by the word transformed. I want you guys to pay attention to that word, because it's a buzzword within cancer biology and within cell biologies. When a cell line becomes transformed, it's not behaving normal anymore. It's not listening to growth signals or cues. It's doing whatever it wants to do. Now, there's a great text. It's a story of a woman named Henrietta Lacks. Has anybody heard of Henrietta Lacks? So this text of Henrietta Lacks, this was a black woman in the United States that was diagnosed with cervical cancer, okay? And her physician took a sample of her cancer without her knowing it and without her permission. And those cells that, we're talking decades ago in the United States, okay? Mid-20th century. Mid-1900s. And he was curious about it. So he grew them in a laboratory. She passed away. Grew them in a laboratory, and these cells would divide and grow, and then he could take them and put them in another dish, and they'd divide and grow, and then he could do that again and again and again, and they never tired. They never wore out. And he told all of his colleagues, and they said, well, send me some of the cells. So he shipped all these cells around all to his scientific colleagues, and they started growing the cells. These cells are transformed cells because they're cancerous cells, and they won't ever stop dividing. The word is they're immortalized, okay? So he didn't name them Henrietta Lacks cells because that would be too obvious, so he called them HeLa cells. HeLa cells. So HeLa cells are one of the most popularized cancer cell lines that are used in research today, and the Lacks family got this much money for grandma's cells. It's been the subject of so much controversy in the states. It's been in the, the state Supreme Courts, and basically where the court system ended on was, and this might bother you guys, it's a side tangent, but I think it's relevant, is once your cells leave your body, they're no longer yours. So the Lax family had no claim to them. But that changed the way HIPAA laws and informed patient consent takes place today, right? Now you go get treated and you're like, holy crap, didn't I already sign this form? Like, I think I've seen this one already, right? You got to sign so much stuff. It's because of situations like that. So the HeLa cell line, Henrietta Lacks, give her credit for her own cells, these things are immortalized because they've been transformed. So let's talk about some terminology within cancer biology. And we'll come back to immortalized cells in just a minute. A lot of times the terminology, but it's getting sloppy. Now the field of cancer, there's so many newly discovered cancers. And to Max's comment earlier, like, we're already there, where we're pre-screening for everything now. And I think in your lifetime, it's only going to become more regular, more aggressive, and more commonplace, okay? Oh, for sure, because a lot of it's radiation. That's how you take the picture. So you want to, how much radiation do you want to get to see if you have cancer? After your 100th scan, now you probably have radiation cancer, right? You have cancer after your, I mean, I just made that up, but that's one of the ethical questions is, how much do we want to do this? Right here and then in the back. Good question. So a couple slides ahead, but that's okay. Question is, if you took a normal cell and you grew it in a petri dish, how many generations could it grow, right? So it depends on the cell. So for example, in my lab, we'll grow fibroblasts, normal fibroblasts. And you can buy them commercially, you can get them donated. But normal skin fibroblasts, they're good for about 7 to 12 generations or passages. Then what happens to them? Well, they just sort of poop out. They stop really growing, and they actually don't look like fibroblasts anymore. They actually differentiate into other types of cells that don't resemble fibroblasts anymore. So to answer your question, it depends on the cell, but usually single to maybe low double-digit passages. But like the HeLa cell lines are, I don't know, 4,000, 5,000 generations now, and they look exactly the same, right? They're truly immortalized. So that's the difference. That's also why scientists like working with them, because you have the same cell for every single experiment. Okay, there's another cell line that's pretty popular now. It's called the Hockett cell line. It's a keratinocyte, and it's immortalized, but it doesn't have as cool of a story, so I didn't really talk about it. Yes? Okay, so here's the question, which is an insightful question. And I can see that we're only going to get so far today, and that's fine. And then we'll finish it up on Wednesday. We're not going to push it. We'll go the pace that we need to go, okay? So, but I will get to vascular, okay? So I'm not pushing you off because I will talk about it. So the question about that's posed is cancer potentially getting smarter? Like we see superbugs, bacteria is becoming antibiotic resistant. We see new viruses, right? Although the one that we're wrestling with today isn't necessarily new. But we're seeing newly discovered viruses and bugs that seem to be getting more sophisticated. And cancer is actually doing the same thing. So how is that happening? I don't know. Because it's not necessarily a contagious disease. But so let me explain. Now, and we're going to talk about this on Wednesday, now our cancer therapies are having to become more sophisticated than the cancer therapies 10, 20 years ago. So now what we have is we have cancer lines now that are non-responsive to conventional chemotherapy. That's the terminology. So The oncologist might say, you know what, we're going to try this chemotherapy first, and if you're non-responsive, then we're going to move to something else. And that's what they do. And what we're seeing is we're starting to see a shift with cancer where some of the classic chemotherapy agents, chemotherapy is just a chemical compound, a drug that you deliver to a patient that's literally a poison. And a lot of them poison fast replicating cells. And cancer is a fast replicating cell, high mitosis. And so it kills a fast replicating cell, and the idea is to kill it faster than the side effects of killing your other cells in your body. But that's why patients on chemotherapy feel miserable, because your gut epithelium is a fast replicating cell. That's why they lose their hair, because your hair follicles are a fast replicating cell. So you're literally taking a poison, and you're betting that the cancer is going to lose first, and the rest of your cells are going to still be resilient. So that's why I always say, like, so-and-so is recovering or is in between chemotherapy. I'm getting stronger. My last chemotherapy was 2 weeks ago. I'm getting stronger. I'm going to go back on chemotherapy. They're trying to give the body time to recover so they can poison it again. That's what we do. We're playing this game of poison and recover, and then we try to get the patient into remission. And now we're trying to get more sophisticated so there's less side effects, but also some of the cancers that traditionally responded to some drugs are no longer responding. I don't know why, but they're mutating, and obviously they're continuing to mutate. Okay? For some of the, like 5-fluorouracil is a classic chemotherapy drug, and it just targets all fast replicating cells. It's not specific. It hits everything that replicates quickly. Correct. You kill the cancer first, and then you take them off the drug, and you let the patient recover. Well, now we have targeted chemotherapy, but I'll talk about that on Wednesday. Okay? So does that help a little bit? Yeah. So I mean, we could talk for hours philosophically on why is cancer getting more aggressive, and why are new cancers showing up all the time. What's that? Yeah. So let's talk about those theories in office hours. Okay? Let's do that. Come into office hours. Now I'm pretty much in my office now on Mondays from about 11:30 all the way to 1:30. Okay? And Richard shows up, and then we walk down here. So I might be, as some of you know, you caught me today, I might be stuffing my face with an apple or an orange or, a sandwich or something, but we can talk through all these kinds of things. It's fun, it's fascinating to talk through. Okay? Let's talk about terminology. So this does relate. We used to have very conventional names, and we still do, but because there's newly discovered stuff happening so quickly, the conventions are starting to get sloppy. But they're usually named based upon the type of tissue that they come from. So for example, a carcinoma or an adenocarcinoma or a sarcoma, a leukemia, a lymphoma, or what we'll call a CIS or a carcinoma in situ. So a carcinoma are typically transformed epithelial cells, like skin neoplasms. Basal cell carcinoma, for example. So basal cell carcinoma, what cell type do you think it affects? Stratum basale of the skin. Okay, that's a basal cell carcinoma, which is a skin cancer. How about a melanoma? The melanocytes, okay, the ones that make the melanin. So a carcinoma is this picture, this nose picture. You've got a squamous skin carcinoma in the upper right. So that's the squamous cell. So that's going to be in the topmost layers. That's why it looks really open and raw. Okay, that's a squamous cell skin carcinoma. Adenocarcinoma, usually epithelial cells of glandular tissue, like an adenocarcinoma of the prostate, which is this lower left. So this is a really cool slide, okay, to kind of geek out on. But I just had a family member pass away in the last 2 months from prostate cancer, okay? And so, this one's even kind of tough to look at. And this isn't his sample, but, he would have given it to me. I mean, honestly, he would have. But so, do you see these cells right here, right in the middle? These are normal prostate cells, glandular cells. And then do you see the cell over here, and this cell right here, and then this one up at the upper left, like at the 11 o'clock position? Can you see some differences between these cells? So normal in the middle, and then look at this overproduction of cellular division. You guys, can you appreciate that? There's way more cells outside of the border. You see this little pooch right here? It really should be nicely, tightly circumferential, like what you have here around the lumen. And this one still is circumferential, but look at how much thicker. And you can see these are densely packed and these are wide open. So they are transforming. They look different. So if a patient, dad or grandpa says, hey, I had a biopsy, and they took a biopsy of my prostate, okay, this is what the pathologist is going to look at to say, okay, we've got a problem. Okay, so that's an adenocarcinoma, glandular tissue. Epithelial cells of glandular tissue. Okay, back up. We talked at the beginning of the semester about an adenocarcinoma. Which one was it? Do you guys remember? It was Barrett esophagus. It was called esophageal adenocarcinoma because it's in the esophagus and it's glandular tissue now because it's mucus producing, right? So that was the esophageal adenocarcinoma that we already looked at. Okay, a sarcoma. Usually a sarcoma is transformed connective tissue from the embryonic mesoderm. I don't have a great picture of a sarcoma, but you can, that's the middle tissue layer. Sarcomas are going to be found in like muscle tissue. They'll be found within the abdominal cavity, okay, a sarcoma. A leukemia, cancer of the blood or the bone marrow. So that's the blood smear here. So if a patient has a bone cancer, it's a leukemia. If they have a blood cancer, it's a leukemia. For leuco, right? The prefix leuco, like leukocyte. And then the last one, but again, this isn't necessarily the only classification, but these are the big ones, lymphoma. So a lymphoma, which one do you think this one characterizes? Lymphatics, lymph nodes, okay? The lymphatic circulation. So this is an arm that looks like a calf, right? And this is a lymphoma within the forearm where the lymph nodes are located in the arm. Your lymphatics circulate and basically parallel your veins, right? So you could have a lymphoma pretty much anywhere in the body within a lymph tissue. Yes? Yeah, so the sarcoma is referring to the mesoderm layer. The mesoderm layer. So that's the middle layer embryonically. You've got ectoderm, mesoderm, and endoderm. So the middle layer is going to give rise to like bone and muscle. So if you have like a bone cancer, not bone marrow, but a bone cancer of the actual hard bone, cancellous bone, or if you have muscle lesions, that would be a sarcoma. Okay? This last term that's on the slide is called the carcinoma in situ. This is really an early type of form of cancer that doesn't have invasive tumor cells yet. So it's a carcinoma and it's still in location. That's what the in situ means. It's found still in location, so it hasn't yet metastasized. It's usually found, a CIS or a carcinoma in situ, it's found before it's actually perforated the basement membrane. So you've caught it early enough before it's metastasized. Okay, so that's kind of its own category all on its own. In a CIS or a carcinoma in situ, it could be in any one of these classifications. You could have a carcinoma in situ that's a sarcoma that's still found within the muscle and it hasn't penetrated the basement membrane, for example. Yeah.
Is that sometimes confused with being benign?
Yeah, so oftentimes a carcinoma in situ, it's another terminology for a lesion that's still in a benign stage. So it actually hasn't metastasized yet, and it's lower risk. Yeah, good question. What's that? You can tell that that's the direction it's headed. It's headed for malignancy, is where it's headed. So this is in the colon. This is a polyp. It's benign. It's a stalk-looking like structure where you've got the normal gut epithelium here. This is within maybe the large intestine. And here at the sort of convex portion of it, you've got this proliferation that's taken place. So kind of this mushroom piece of tissue isn't supposed to be there. And this is what they would see under histology if they went in on a colonoscopy and said, hey, we're seeing polyps of the colon. What are polyps of the colon? They're these little protrusions that are growing that aren't supposed to be there. They're typically benign, and so they'll come in and they'll snip them off, or they'll band them. They'll tie a band here, and then they'll snip them off, and then they'll send them out for histology, and then we get pictures like this. And they'll say, yeah, we're going to watch this. We're going to come in maybe annually, take a look. If you have any polyps, we're going to snip them and see you next year. The whole idea is they don't want this. It's fine, really, if it grows this direction, but if it breaks off and it starts going this direction, now it becomes malignant, and that's colon cancer. So colon polyps are a pre-cancer, benign, okay? They're not colon cancer, but they're concerning because you aren't supposed to have this tissue growing. Does that make sense? So it's abnormal. It's something you want to watch for, but it's very manageable at this stage in our healthcare. Yeah, so the question is the polyp functional tissue? Well, it's not completely non-functional, but it's not going to operate the way it's supposed to because you either have secretion or absorption happening within the gut. And so if you have this giant growth out here, you're actually impeding diffusion one way or the other. Okay, so it's going to resemble the glandular-like tissue of its surrounding tissue. So technically it's still functional, but it's not physiologically going to be serving the purpose, not helping. It's not necessarily helping. Does that make sense? Kind of that differentiation there? All right. So we talked about immortal. And I'm just kind of looking ahead and seeing that if we're going to be talking about we're going to have time to talk about angiogenesis for Max. So transformation in immortalized cells. So the question was brought up. If you have a petri dish and you take some normal cells and you put them in a culture, what happens? Well, they grow. They actually grow to fill the entire surface of the dish, and then they stop growing. It's called contact inhibition. So it's as if you filled this room with cells. They would grow until they formed a lawn on the floor. Once they hit the edge of the wall, they would stop. Okay, that's normal behavior, contact inhibition. Cancer cells don't stop. They just grow up the sides of the wall. They'll grow on top of the other cell layer, so it'll be multi-cells thick. They don't have contact inhibition. So they stop responding to these signals. So this is called density-dependent inhibition or contact inhibition. And normally, they'll stop when they hit the edge. Cancer cells will just grow on top of each other. They won't stop. They lose their ability for anchorage dependence. So they're anchorage independent, meaning they don't actually have to touch plastic. They don't actually have to touch the floor, the substrate. They'll just grow on top of each other. They don't care. That's called anchorage independent. Autonomy, that's that word for contact inhibition, they ignore it, or density-dependent inhibition, they ignore it. They act autonomous. That means they act on their own without any attention to outside growth signals. We call them immortal. Immortal means, like we talked about with the HeLa cell lines, immortal means that they have an infinite ability to divide and stay exactly the same. Okay, they're kind of like this vampire-like cell. So that's cancer's business, is it mutates to a point where it just continues to grow again and again and again and replicate again and again and again. And that's the immortal cell of Henrietta Lacks. That's the HeLa cell line. That's the Hockett cell line. That's most cancer cell lines become immortal. Now, they have two characteristics that are very important for us to describe. One is anaplasia, which is a loss of organization, and secondly, an increase in nucleus size. So they become less organized, and their nucleus gets big. And why do you think the nucleus enlarges in these cells that are immortal? They're replicating so much that the nucleus just gets big. Okay, you can see, I'll show you some pictures histologically. It's pretty interesting. And then this last term for cancer cells is pleomorphic. Pleomorphic means that they have multiple morphologies. That's pleo meaning multiple and morphic meaning shapes. So they have a variable shape or size. Pleomorphic. Varied shape. Okay? So back to our uterine cancer. It doesn't have a shape that looks like or myometrial muscle. There might be some that look like that. There's others that are round. There's others that are oval in shape. So variable shape and size, pleomorphic. So how do these cells actually become immortal? And this is, I think, one of the most fascinating pieces of cancer biology. And this is related to some genetic information that's found within all cells, and it's called a telomere. And the telomere responds to an enzyme called telomerase, which actually makes it a little bit longer. And the telomere is at the end of all DNA to protect it. Because DNA replication, as you all know, is a very aggressive process. Like you tear the double helical DNA apart, and then you allow for nucleic acids to spontaneously anneal, and you hope that you get everything right. You check it for errors, and if there are errors, you make the correction. But the telomere is directly related to the ability for a cell to replicate. So let me explain. In our older population, with an aged cell, we said age is a pathology, right, in the beginning of the semester. With an older cell from a geriatric patient, telomere length is very short. Their cells are not capable of dividing nearly as robustly as yours. And your telomeres are actually much longer. And as we age, telomere length shrinks. And so that's one discovery in the literature on telomeres is the older the patient, the shorter the telomeres. So if you have a way to lengthen telomeres, you could theoretically lengthen lifespan. Because there's no great explanation as to why do cells run out of the ability to replicate as you get older. This is the explanation, is because of it's directly related to telomere capability. Okay? So if you look at our germ cell line and you look at telomere length, the germ cell line from our gametes never changes. And that's why we can continue to replicate, right? And you have species that can have next generation. Our stem cells, the number of cell divisions, it does decrease over time, but it stays much closer to the germ cell line than a normal cell line. As the normal cell line goes through cell divisions, the telomere length shrinks. So the fibroblast that's in culture, why does it only go really out to 7 to 12 generations? Because we start losing our telomere over time, and it just goes into a stage of what's called growth arrest. Now, and then I'll answer your question, look at what happens to cancer cells. At some point, they mutate, and their telomeres actually lengthen. In cancer cells, they have longer telomeres than normal cells. So it's genetic information right within the cell that's on the genome, on every gene, and it's like a little bumper of genetic material. And that telomere actually preserves the integrity of the genetic information behind it. And so the shorter the telomere, right, the less integrity you have on that DNA, and the less capable it is to replicate. Yeah, it's a bumper. It's like a pad, like a protector of the DNA. So let me show you this study. Came out of this. It was popularized in this magazine, and this is what caught my attention. This is The Year Man Becomes Immortal. It really has nothing to do about, what the picture on the cover would suggest. I really picked up this coffee table magazine because of this article. And this publication came out in, what does that say? 2011. And this is the article that I wanted to highlight. And In 1985, there was an investigator named Dr. Elizabeth Blackburn, and she was at UC Berkeley. And her graduate student at the time, Carol Greider, who's now at Johns Hopkins, they discovered this new enzyme known as telomerase. And telomerase acts in our bodies to lengthen telomeres. And so as you're younger, your telomerase activity is higher, and every time you replicate, your telomere gets a little shorter, right, because it's an aggressive process. But telomerase kicks in, and then it lengthens and extends it. And that's why you can go through divisions, and the telomere is kind of shortening and lengthening, shortening and lengthening. And these two individuals, Blackburn and Greider, discovered telomerase. When it was active in cells, the telomerase lengthened the telomeres and prevents chromosomes from being whittled down as the cells continue to divide to replenish their numbers. Now, for their study on telomerase and telomeres, they shared the 2009 Nobel Prize in Physiology, these two women. And there was another telomere researcher by the name of Jack Szostak from Harvard, who shared the telomere Nobel Prize in 2009 with these two ladies. But this article is kind of characterizing in Popular Coffee Table magazine. It's not a peer-reviewed journal, but I wanted to read this for you. So it says, every time a cell divides, its telomeres get shorter. This might help answer your question a little bit. It can't reproduce anymore. Oh, sorry. Every time a cell divides, its telomeres get shorter, and once a cell runs out of telomeres, it can't reproduce anymore and dies. But there's an enzyme called telomerase that reverses this process. It's one of the reasons cancer cells live so long. And so this is what caught my attention because I wanted to talk about it in this lecture. So why not treat regular non-cancerous cells with telomerase? So in November of 11, researchers at Harvard Medical School announced in Nature magazine, which is a peer-reviewed publication, and you can go look up this article if you want, that they had done just that. They administered telomerase to a group of mice suffering from age-related degeneration. The damage went away, and the mice got younger. Okay? Categorically, they got younger. So can we translate this into humans? Possibly. We haven't been successful yet. Okay? There's a lot of research that works really well in the laboratory and in mice, and then it never translates into humans. But I thought this was a fascinating journal. I mean, it looks like this guy lives in Flagstaff, but he doesn't, because you know he doesn't live here because there's too much water, right? Other than that, he looks like you would find him somewhere downtown. But this Time magazine article does a really nice job of characterizing this Nature publication that's talking about the impact of telomeres. And telomeres are important not just for cancer, but they're also important for you and I, and why we have sort of an age limit, right? Humanity lives to a certain age, and men and women, and then we are done. And nobody's really been able to answer that question until we've discovered telomerase and telomeres. All right, question that I'm going to pose to you. You've just told your patient he has a lipoma. He expresses concern because his sister recently was diagnosed with a liposarcoma, and it sounds like he has the same thing. So what do you tell him to calm him down? Talk amongst yourselves. All right. What are some thoughts, ideas? Any clues? Yes, sir.
So the lipoma, is that kind of benign? It's still benign?
Yeah.
That's what I would call it, that liposarcoma is where it penetrated and it spread. Where in his case, we caught it early and it's still benign and very treatable.
Perfect. Yeah. Except maybe take the word kind of. Other than that, you got it down. The lipoma is kind of like benign, right? Just say it's benign. We've caught it early enough. But that's perfect. The lipoma, the oma, is a benign suffix. In sarcoma, the suffix is malignant. Okay, perfect. 2 histology pictures. One of these is what? What is this tissue? Normal. One of them's normal. What is that tissue? Upper right. What does it look like? Histology, H&E. What is it? Skeletal muscle. Well done. Nailed it. This is skeletal muscle, okay? The nucleus are on the periphery, right? That's a myocyte. You're looking at it in cross-section. Anaplasia, loss of organization and increase in nucleus size. And then pleomorphic, variable shape and size. Look at what's happening down here. What is that a picture of? Is that muscle? Not anymore. What is that? That's nasty. That's a rhabdomyosarcoma. A rhabdomyosarcoma. R-H-A-B-D-O-M-Y-O sarcoma. S-A-R-C-O-M-A. Rhabdomyosarcoma. Now I got to look it up. What did I say? Rabido. So here's what I want you to know, and this is where we're going to end. Look at the loss of organization. That's pretty obvious. Look at the increase in nucleus size. Look how big this one is. This one, compared to those. Same magnification view. And then pleomorphic. Variable, look at this cell size that's still in. And then look at this one. This one's long. This one's circular. This one's like a polygon. So oftentimes in cancer, you're going to see both anaplasia and pleomorphism together. But they are different definitions. And I want you to be able to distinguish between the two. Let me repeat that. I want you to be able to distinguish between the two, anaplasia and pleomorphic, on an exam, for example. Is that a big enough hint? Okay, I hope so. All right, we'll pick up with tumor markers on Wednesday. See you guys Wednesday.